My name is Patrick van Rheenen. I'm a pediatric gastroenterologist working in the University Medical Center in Groningen in the Netherlands, and I'm the head of the Pediatric IBD Unit. Inflammatory bowel disease has two distinct phenotypes, Crohn's disease and ulcerative colitis. Crohn's disease can have inflammation throughout the gastrointestinal tract, and in ulcerative colitis, the inflammation is in the colon. Approximately 3 million people in Europe suffer from IBD, and 10% of them, 300,000, are below the age of 18. The reference test for diagnosing IBD is endoscopy, which is an invasive procedure. People need to undergo a bowel preparation, and children need to undergo this procedure under general anesthesia. So you don't want to expose all patients to this invasive procedure. You only want to expose those with the highest probability of the disease. Well, in order to overcome these challenges, we need to screen patients, and the better word is triaging patients, so that only those with the highest probability of the disease are exposed to endoscopy. So the patient will always come with symptoms, and if there is a combination of suggestive symptoms and an increased fecal calprotectin, then the probability is high for IBD. The strategy that we use is we look for suggestive symptoms, also called red flags, in combination with a raised calprotectin level, and then we mean a test result above 250 micrograms per gram in the absence of colon pathogens. So if patients have this combination, they have a high likelihood for the disease. We follow up patients by monitoring fecal calprotectin and symptoms, and in patients who are on anti-TNF treatment, we also do trough levels. I distinguish two scenarios. The first scenario is the patient with active disease, with high levels of calprotectin, and these patients are on remission induction therapy. We measure the calprotectin once every month. In the second scenario, the patient is in remission, the levels of fecal calprotectin are low, and in that situation, we measure calprotectin levels once every 3 months. I consider the treatment a success when we have reached the target range for fecal calprotectin, which is 250 micrograms or below. A drop in calprotectin levels from 2000 to 1000 is, in my opinion, not a treatment success. Only when we have reached levels below 250 micrograms per gram, the patient has reached remission or is having mucosal healing. If you want to use fecal calprotectin in pediatric practice, I have a few recommendations. The first one is to try to collect a morning stool after a night's sleep. The second recommendation is to store a stool sample in the refrigerator until analysis. And the third, and in my opinion the most important recommendation, if you want to follow a treat to target strategy, always use the same assay.